this is the new diagnostic criteria for NF2. Now, I'm not going to spend a lot of time going into this. There's not all of that much that I think as a patient or family member, need to know about the specifics, other than you can make the diagnosis of NF2 based on clinical criteria. So having a certain subset of the different symptoms that we associate with NF2. And the most important thing, in my opinion, that came of this whole process is that genetic testing became an additional feature that you could use to confirm a diagnosis of NF2. So I just highlighted some of the things that were changed. There were some other things that needed to be cleaned up. So in the original diagnostic criteria, glioma was listed as a tumor type. In fact, people with NF2 don't really get gliomas in the sense that we typically think about them. They get something called ependymomas, which are a subtype of glioma. Changed the wording around who the first degree relative could be that would count, and clarified a little bit about some of the eye findings. But again, the most important thing is the fact that now genetic testing is part of the diagnostic criteria. The original diagnostic criteria were developed before the gene was identified, and so it really wasn't part of the original diagnosis. And why this is important from a patient perspective is that this will help genetic testing get paid for by insurance companies, and hopefully will make it more accessible to a much larger portion of the population. If genetic, honestly, insurance companies, they're in the business of paying for as little as they possibly can get away with. And if they don't see something in print that says you need a genetic test to make a diagnosis, they'll say, well, it's not in the literature. You don't need that. So why are we going to pay for it? But in fact, it can be very valuable, as I'm sure many of you know, and that would be a talk all unto itself, what the role of genetic testing is, specifically for NF2 and Schwannomatosis. But it helps us with knowing what to expect for the future. It helps with family planning, and it helps with specifying and identifying, really clarifying what the diagnosis is. So it's also important to know that genetic testing in NF2 related schwannomatosis is not perfect. It's good, but it's not perfect. You will find it probably in about 70% of individuals with NF2. It's a higher rate if it's familial. If you have other family members with it, it's lower if you're the first person in your family identified with NF2. You don't need to have genetic testing for NF2 diagnosis, and conversely, just a mutation, but no other clinical features or no family history is not enough to make the diagnosis. So you either have to have a family member that has NF2 and you have the identified mutation, that's enough, or the mutation or the pathogenic variant plus some clinical features of neurofibromatosis type 2. Is that pretty clear? Great. In some ways, the schwannomatosis diagnostic criteria are simpler, and in some ways, they're more confusing. So the schwannomatosis naming and criteria are very gene-based. So what was previously called schwannomatosis included people with LZTR1 mutations, it included people with SMARCB1 mutations, and it included people that had symptoms of schwannomatosis, but no gene was ever found or looked for. So now that entire group has been split up into smaller subsections. They're still all schwannomatosis, but now it's LZTR1 related schwannomatosis, SMARCB1 related schwannomatosis, 22q related schwannomatosis, which means that you don't know exactly which gene is affected, but you know that that general area of the chromosome is involved. Or you're indicating that genetic testing has not been done, so we just know that it's schwannomatosis in general. It's called not otherwise specified, NOS, which is the top one here. Or you've done all the genetic testing you can, but you can't find a gene. And you know it's schwannomatosis, and you know there's probably a genetic change, but you just can't find it. And that's called not elsewhere classified, or NEC. So if someone comes into the clinic with 2 schwannomas, you can say that they have schwannomatosis. But at that point, if you just know that, let's say they have a schwannoma that's been taken out in their foot and they've gotten a pathologic diagnosis of a schwannoma, and there's an MRI that shows another schwannoma in the right hip, you know that they have schwannomatosis, but you don't know if they have NF2 related schwannomatosis, LZTR1 related schwannomatosis. So we know it's in that schwannomatosis larger umbrella. So at that point, just starting right there, you have schwannomatosis NOS, not otherwise specified, because you haven't done any additional workup. You haven't done any genetic testing. So we just know it's schwannomatosis. So let's say the next step is you get a brain MRI because this person had a lump in their foot and you're worried about schwannomatosis and you want to see if there's anything going on in the brain, and you see bilateral vestibular schwannoma. That's enough at that point to make a clinical diagnosis of NF2 related schwannomatosis. So that takes you out of this category and puts you into the NF2 related category. If you don't see anything on brain MRI, then you still don't know which type of schwannomatosis this is. You're still in this not otherwise specified category. And you're there until you either do additional genetic testing, both on blood or saliva and on tumor. And it can be really helpful to do genetic testing on both. And do typically in clinical practice, do additional imaging, though that's not necessary for the diagnosis. So if you go down that path and you do some additional genetic testing and you find the SMARCB1 gene or the LZTR1 gene or the 22q related changes, then you can subcategorize somebody into that different category of schwannomatosis. Why does this matter? I didn't, without the slides, I sort of skipped some of the why this matters section. It really matters for clinicians and for researchers for one set of reasons, and for patients and families for another set of reasons. For researchers, if you're researching a disease and you want to figure out how to cure that disease, how to treat it, how to diagnose it, how to manage it, if you are actually talking about 6 diseases that are all are in the same, that are sort of similar, but not exactly the same, it's much harder to come up with treatments, come up with plans, and actually really understand that disease. So from a research perspective, that's really key. From a clinician standpoint, it's really important to be able to divide between different types of condition, because it may mean different things for the patient. So you may educate them about different things to watch for. You may offer them different treatments. You may have them get different educational materials. All of these different things have important ramifications. For patients, if you know specifically that you have a particular condition, you can then have a community of people with similar issues that you're facing. So I would imagine that some of you have experienced, if you go, even within CTF, right? So within CTF, you come to these meetings or you go to the website, you learn a lot about NF1 and you learn a lot about the issues of NF1. And that's important, but it's not always so relevant, right? And you can imagine 30, 40 years ago, if this was just the NF conference and we were all talking about all the NFs all together, you're not really going to build a community of people that are similar to you in terms of the things that you're facing. So having a better understanding of the specific diagnoses are important to the community in that way. And I'm sure there are other ways that I'm not thinking about at the moment, but I think I would imagine that most people feel like being specific about which condition they have is helpful in a number of different realms of their lives. So there is a really big overlap between what was previously called NF2 and schwannomatosis, and that overlap is becoming more and more understood over time. And so the new diagnostic criteria and new naming address some of that. It really highlights the difference between NF1 and the schwannomatosis conditions, which is, I think, really important. Hopefully it improves diagnostic specificity and sensitivity, so we're better at making the diagnosis accurately. It clarifies some of the diagnostic features. So what we're learning is that SMARCB1 schwannomatosis is different clinically than LZTR1 schwannomatosis in terms of rates of pain, in terms of rates of vestibular schwannomas, in terms of rates of meningiomas. So identifying these different subtypes is really important for us to clarify the diagnostic features and clinical features. And as I mentioned a couple of times, it really highlights the importance of genetic testing. So hopefully we can get people better diagnosis earlier. And Vanessa Merker, who was leading this session before, did an excellent paper several years ago about how long it takes people specifically with schwannomatosis to get a diagnosis, how many doctors they see, how many years it takes. Hopefully this will lead to less confusion about the different conditions. Hopefully will improve insurance coverage for genetic testing, lead to better quality data from translational and clinical studies, and again, probably much more than just that. So I purposely tried to make this talk shorter than the full 50 minutes because I want to hear from you guys, and I want to generate some discussion about, well, first of all, the name. I mean, I'm going to guess that not everyone loves saying NF2 related schwannomatosis in particular. It doesn't roll off the tongue. So we'd love to hear more about people's thoughts around that. And just sort of in general, what we've talked about. And also, of course, if there are any questions about, this is a lot of information and some of it's confusing to me as a clinician who's been doing this for a long time. So yeah.
I'm not sure if did you say, what was the time? Oh, sorry. What was the timing for determining the differentiation between schwannomatosis and the NF2 related schwannomatosis? Because the reason I ask, I had genetic testing done maybe 5 years ago. So would the determination of my results possibly be different now based on the new criteria?
Right. So I'll answer that specifically, but more broadly, that's a really important question because over time, and this is one of the things about genetics is changing all the time. Our ability to identify pathogenic variants or mutations gets better all the time through technological reasons, as well as understanding which genes are involved. So historically, the NF1 gene was found in 1990. The NF2 gene was found in 1991. SMARCB1 was found in 2007 or 8. And then LZTR1 was found in 2014. And 22q as a sort of separate entity is even more recent than that. So if someone in the schwannomatosis diagnostic realm has had genetic testing that was either nothing was found, if nothing was found and that was done more than say, 5-10 years ago, that probably should be repeated or could be considered to be repeated. If something was found, so if an NF2 mutation was found or LZTR1 mutation was found, that doesn't really need to be repeated. At this point, there's not any additional information you're going to get by repeating it.
It wouldn't affect treatment.
So if you have a known gene, yeah, the mutation, the specific mutation would be in the original testing. And Rina or Jay should correct me if I'm wrong, or Tina. I mean, there wouldn't really be a value in repeating it per se. The one caveat to that is if there's some thought that didn't talk about it, but there might be mosaicism, meaning that not every cell in the body has the mutation. If someone had a high level of mosaicism in the past, it might have just come across as a mutation, but it might actually be mosaic, which could be picked up on more recent testing, which might indicate a more benign course, but that's complicated. But that's a very small exception. Yeah.
I totally agree. And I might add, it depends on how you see your results. Some results come back as NF2 yes, NF2 no. If it came back that way, I would want more information, and that might require additional testing. If it came back NF2 and then you get a whole bunch of jibber jabber of QT4 period 148, then that's the specific type of change in the gene. And that change in the gene can give your clinical team some clues about how to think about the risk. So you want as much information from that testing as possible. But if you have all that, I agree, not very likely to change the information to retest.
Yeah, that's true. I mean, and this actually still happens sometimes. There are people who will do something, they'll do a test that just answers whether or not there's a mutation in the NF2 gene, but not where the mutation is. And that's not as useful. So yes, I would redo it in that circumstance, but hopefully that doesn't happen too much.
I apologize if I missed this, but could you explain the new term hybrid nerve sheath tumor? I think that's sort of newer lingo in the last year or two.
Yeah, so the question is about the use of the term hybrid nerve sheath tumor. So I'm going to back up a little just to give us all sort of a baseline of terminology. So nerve sheath tumor is a broad umbrella term, sort of like NF is a broad umbrella term that's covering everything. So any tumor that grows from a nerve sheath is a nerve sheath tumor. Nerve sheath tumors come in two, or actually three main flavors: neurofibroma, which is actually Schwann cells plus fibroblasts plus pericytes plus mast cells. It's sort of a conglomeration of a bunch of different cells. Schwannoma is predominantly just Schwann cells that have grown, overgrown. And then the third category is malignant peripheral nerve sheath tumor, which is when a nerve sheath tumor undergoes transformation from benign to malignant. As I sort of alluded to earlier, neurofibromas and schwannomas are different, both in the types of cells that make up the tumor, like I just described, also the way they grow in relation to a nerve. So schwannomas tend to be more on the outside of the nerve, with the nerve sort of displaced to the side or above it. And neurofibromas really grow within the nerve so that all the fibers of the nerve are sort of splayed throughout the tumor. There are tumors that have categories that have features of both a neurofibroma and a schwannoma, and that's a hybrid tumor. And this gets into the weeds a little bit, but it's important from a diagnostic standpoint because a lot of times pathologists, they're not as familiar with some of the subtle differences between the different tumor types. And so you will sometimes see somebody that for all intents and purposes, you know has schwannomatosis, but you're getting a pathology report that says nerve sheath tumor or neurolemoma or neurofibroma or a variety of different terms. And when you then look at it more closely with someone who's really familiar with all of the neurofibroma and schwannomatoses, they will come back with a more clear definition. And sometimes it's that hybrid tumor where there are characteristics of both. So people with NF2 and schwannomatosis can have hybrid tumors, but they almost never have pure neurofibromas. Does that make sense?
Do you have a sense of what the clinical manifestations, or can you predict what is going to be studied about the different clinical manifestations between LZTR1 and SMARCB1 versus 22q?
Yeah, so I think I think there's several things. I think malignancy risk, so the risk of a schwannoma undergoing transformation from being benign to malignant may be different between the two. The relative incidence of pain may be different, and the mechanism of pain, I don't know yet, or we don't know yet, but there may be different mechanisms of pain, and there may be therefore that treatments for pain may work differently for the two different conditions or three different conditions. The risk of additional tumors like meningiomas, unilateral vestibular schwannoma, for instance, is more clearly associated with LZTR1 than with SMARCB1. So you may actually end up following someone differently because you don't have to worry about the development of tumors in the brain as much in SMARCB1 as you do in LZTR1. So I think it has a lot of potential implications. How important those implications will end up being, I think, remains to be seen.
Hi, my name is Ken. I have NF2. I was really interested in this presentation, but unfortunately, I'm not able to follow it without captions. They don't have captions set up. So I'm wondering if, do you know, maybe you're not the right person, but do you know if this will be recorded and broadcast? And if so, will it have captions when it's rebroadcast?
Sorry, thank you. Yeah, is it picking me up for you? Is it working? Yeah, absolutely. So we are supposed to have captions in this room, and we had an unexpected technical issue, which I am very sorry for. We are recording presentations, and they would be captioned when we shared them. I'm sorry, Ken. Yeah.
Any other questions, thoughts? How do people feel about the name? The Gribbon say no.
It's a mouthful.
It's a mouthful. You know, I think my guess is that for a while, people are going to still call NF2 related schwannomatosis NF2. And just, I think the term neurofibromatosis type 2 will more quickly disappear because I don't think most people use that on a day-to-day basis anyway. And I think most people with one of the schwannomatoses, previously called schwannomatoses, will just say that they have schwannomatosis. And I think most people with NF1 will continue to say they have NF1. So I don't think on a day-to-day basis in terms of the community, in terms of fundraising, in terms of organizations like CTF, I think that on a day-to-day basis, not much is going to change. It does help the research community and the medical community, I think. And as this sort of spreads out into doctors who are being trained now, so they really understand the difference, some of the impact of this won't be until they are practicing clinicians in the not too distant future. So it's a beginning, but we are at the beginning and change is hard. I know that's a trite thing to say, but I don't think it really will make too much day-to-day difference for anybody. And no one's going to yell at you if you use the wrong terminology. All right, thanks a lot.